Welcome to this episode of the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. On today's episode, we will be discussing the article entitled Clinical Characteristics and Therapeutic Outcomes of Pediatric Blepharokeratoconjunctivitis, published in the journal Cornea in May 2023. I'm Dr. Kelsy Steele, your host and the topical editor of the Anterior Segment Disease Care section. I'm thrilled to be joined today by our topical expert for this episode, Dr. A.J. Peiffer. Dr. Peiffer is a pediatric optometrist in the Division of Pediatric Ophthalmology and Adult Strabismus at University Hospitals Rainbow Babies and Children's and University Hospitals Cleveland Medical Center. He's also an assistant professor at the Case Western Reserve University School of Medicine, director of the Pediatric Optometry Residency at UH Rainbow, and a fellow of our academy. Thanks for being here today, Dr. Peiffer.
I appreciate it. Thank you for having me.
So let's start off by defining blepharokeratoconjunctivitis. We could also just call it BKC, so we don't have to keep saying that. What are some of the typical features of this condition?
Of course, yeah, it's a mouthful, so I'll probably say BKC.
Yes.
And in this condition, it's really an acute or chronic inflammation of the eyelids, cornea, and conjunctiva. So that's how they came up with
in the name, right?
So it's very clearly defining the areas of the eye that are inflamed, and inflammation of these vital tissues can result in neovascularization, scarring or opacification, and actually lead to altered visual function.
So what was the purpose of this study? What specific things were the authors interested in finding or exploring?
The authors aim to determine the clinical characteristics, disease course, therapeutic outcomes, and prognostic factors in children suffering from BKC. They were most interested in children under the age of 15 who had been diagnosed with BKC between 2004 and 2020 at two specific Korean hospitals.
Okay.
They paid particular attention to visual acuity, magnitude of astigmatism, corneal lesion size, treatment and management, and then the visual outcomes.
So what did they find?
So retrospectively, they analyzed 137 patients of Korean ethnicity and found 2/3 predilection for female gender with a mean age at presentation of 9.5 years, but symptom onset of 8.3 years. So there was a significant delay in start of symptoms to start of presentation. In over half of the cases, both eyes were affected, and there was an equal distribution of right eye and left eye when there was just unilateral cases. Over 1/3 of the patients reported recurrent chalasia, and other notable comorbidities included rosacea and atopic dermatitis. The ocular symptoms were reported to be actually quite few in this cohort of patients. A large majority of the patients reported hyperemia, but only about 10% reported the complaint of itch. The ocular signs, however, were definitely more predominant. In the prevalent signs included injection, neovascularization, corneal infiltrates, corneal scarring, papillary hypertrophy, corneal epithelial defects, conjunctival follicular hypertrophy, stromal thinning, and stromal edema. So all the things we would typically associate it with a ocular surface inflammatory response. Inferior cornea was involved with these findings in the majority of cases, but there was a wide range in the area affected of the cornea, even 360 degrees, typically associated where the eyelids touch the actual cornea. Following successful initiation of treatment, 95% of cases achieved remission, and a visual acuity improved to 2025 on average. Recurrence occurred, however, in quite a few of these patients, and with each recurrence, there was a positive correlation in the magnitude of astigmatism required for best corrected visual acuity. In younger patients, the pathology and induced astigmatism, especially if irregular, may actually result in amblyogenic risk factor, and compromise visual development. 12 of the 137 patients in this study were determined to suffer from a form of amblyopia as a result of this condition after excluding any other ocular abnormalities and after successful resolution of the inflammation.
Yeah. I mean, I guess it's not surprising, if you think about all of the scarring and irregularity and neovascularization that will happen in one quadrant or two quadrants, that can definitely induce some irregular astigmatism that could be challenging if not corrected, especially in this younger cohort.
Yeah, if you think about they reported their ages on, the mean ages of symptoms and presentation, but if you really
disparity about a year, right?
Yeah, if you look at the range, so when we associate an 8 or 9-year-old, we may think, well, that's too late in the visual development process to develop amblyopia. However, if you look at the range of patients in their cohort, they were actually as young as about 2 years old. So some very young individuals that can be affected by this, and that absolutely is in the amblyogenic risk range. So keeping in mind the age at onset and the amount of relapses that could impact the visual development in even the youngest cohort of patients.
Right. And you did mention that, a lot of these kids were presenting with minimal, if any, symptoms. Is that your experience as well? I know you treat this a lot. Do a lot of the kids that you see, is it more of an incidental finding or?
Yeah, in especially more mild cases, I think it's incidental. Picking this up on just a slit lamp evaluation sometimes is even challenging for cooperation from kids. But what I find is some irregularity to the retinoscopy reflex when I'm determining the refractive error and saying, something just doesn't look right. And you look a little bit closer and you find the start of some of these findings along the lower eyelid margin where it meets the globe. A lot of these patients may have actually had significant reports of recurrent unspecified conjunctivitis treated by the pediatrician. Given an antibiotic for 5 days, 10 days, everything got better. The parents noticed nothing. The kids stopped complaining, and they assumed that it was they were with other kids and they got quote pink eye.
Right, and then they permit it to your chair, like you never get to see.
Yeah, so I think there's a significant ability to kind of recognize that this goes on probably more than what we even know. And in my experience, the kids don't necessarily complain about it. And I think it's probably because it's such a slow presentation that this is sort of a slowly building process. It's not something that's a sudden acute problem, even though it may seem that there are acute exacerbations. Being in the realm of the chronicity, a lot of the times chronic pediatric conditions, kids adapt to that feeling and they think that it's just abnormal.
They're normal. Yeah. Okay. So what are some of the different treatment options discussed? And in your clinical practice, do you have a specific go-to protocol, or does that really vary by the clinical presentation?
Sure. So kind of highlighting the treatment options, it's usually a combination of topical antibiotics and steroids. That's what was used in this study as well. Nearly half of the patients in this study received oral antibiotics, and only a few required oral corticosteroids. 70% of the patients were also instructed to improve lid hygiene and lid scrubs and apply warm compresses. And maintenance therapy was sometimes needed with a combination of these types of things in order to reduce the likelihood of recurrence. And in some cases, maintenance therapy with the use of topical cyclosporin or tacrolimus as steroid-sparing agents was successful as well. In terms of my clinical experience and what I do, I sort of have a set protocol, but it sort of is exactly what was described in this study, is controlling the overgrowth of bacteria, reducing the inflammation, but the presentation does guide what my choices are. So in controlling the inflammation, I use topical steroids. In most cases, I use a combination eye drop just for the ease of use for
Right.
parents and patients.
Mhm.
And then I do have a consideration for the severity in terms of how I like it delivered. So whether it's an eye drop versus an ointment.
Yeah.
In severe cases and in younger children, I do like to use ointment in order to increase contact time, potentially improve the compliance of treatment, and
Right.
limit the amount of inflammation or bacterial overgrowth associated with this particular condition.
Right.
I, in every case, highlight the importance of lid hygiene
Yeah.
and making sure that we maintain a good eyelid margin and good, healthy meibum expression.
Mhm.
That way, we don't allow the underlying root cause of this to continue to spread. And with lid hygiene alone, I find a lot of patients are successfully reducing the number of recurrences each year as they come back, as long as they maintain that
Right.
good lid hygiene.
Good hygiene. Yeah.
Unfortunately, in a lot of these cases,
Not always the case.
children are resistant to wanting their eyelids washed, their face touched. The parents don't like to make their kids scream. Parents don't like to put in drops for their children. They don't like to lather ointment into their eyelashes. So it becomes a challenge.
Mhm.
Plus, with the limited number of complaints by the patient, there's a challenge with the parent sees no problem and the patient's not
Yeah.
complaining, so they just
But do we
discontinue.
really need this? Yeah.
Right. So in these types of considerations, we want to try to use the least amount of necessary therapy as possible.
Mhm.
And then, like the study highlighted, we want to try to reduce the dependency on steroids. So using something like topical cyclosporin, if it's
Mhm.
available to you.
Yeah.
Also tacrolimus.
Yep.
Tacrolimus ointment, the dermatological preparation, has been documented in other studies to be safe and effective in controlling ocular surface inflammation. And I have kind of a set protocol based on other studies, which I won't particularly get into,
Yeah.
to utilize this as a steroid-sparing agent, just like
Yeah.
they mentioned in the study.
Great. So this study took place in Korea with all Korean patients. How does this affect the generalizability of the results, or does it?
I don't think it affects the generalizability. I think it actually adds to the amount of work and amount of studies around the world, because this condition is reported in diverse ethnicities. The information presented may appear to be a narrow scope, but adds to the evidence that even in a small scope of ethnicity, the presentation, the treatment, and the outcomes are very similar across many other studies. So this provides evidence to practitioners that managing this particular condition can be a little bit more standardized across demographics. Yeah. There's not a lot of other types of considerations to be made. It's get rid of bacteria, control the inflammation, and try to reduce the number of recurrences that can affect the quality of the ocular surface.
Right. So as our last takeaway, should we as eye care professionals implement any changes in our care of patients based off the findings from this study?
Yeah, I think we touched on it just a little bit, and I want to highlight that there's a significant amount of recurrences and strong correlation to worsening astigmatism in these patients. So it's not a one and done. While you may feel like there is a strong initial presentation and you quickly get it under control, keep in mind that a significant majority of these patients will have some level of recurrence, likely because they stop treatment or they slowly allow the problem to recur.
Right, or they got a little lax on their treatment.
Right. Yeah. So this is something that I myself make sure to set up some set follow-ups. So regular interval checks, and not allow the patient to just come in when they feel like they have a problem.
Right. Because like we talked about, they're not super symptomatic a lot of the time, so they won't feel like there is a problem.
Yeah. So like I said, they get better and think things are fine. And then it's often much easier when they have an acute flare-up to go to, say, the pediatrician, and they may not treat this the same way as an eye care practitioner or recognize this as much as an eye care practitioner. Because it's a chronic inflammatory process and goes unnoticed and undertreated, possibly, it really can cause a more detrimental sequelae. So we really like to encourage even primary eye care physicians in our hospital system to refer any red eyes for follow-ups to make sure that we're really getting to the root cause of what the underlying condition may be or the underlying cause may be. And then set regular interrupt follow-ups, at least for a couple of years, just to make sure that they're either compliant or they're not having those significant relapses. In most of these cases, when I see an individual have one of these outcomes, I also make sure that I document corneal topography because of the association of increasing astigmatism. There's likely a component of irregular astigmatism and even monitoring for stromal thinning associated with the neovascularization and scarring, because they may actually end up needing a specialty contact lens to maximize their visual potential.
Yeah. We'll send them on over. I'd love to see them.
Absolutely.
Those are some great clinical pearls. Thank you so much for your insights today, Dr. Peiffer. And thank you for listening or watching. We'll see you next time.
Thank you.